Hello. Very good morning to all of you. First of all, let us welcome all of you to this grand gala event that has been organized by the Bengal Urological Society. In the truest sense of the term, it is really an amalgamation of enlightening talks by international and national faculties, together with many competitive sessions for the postdoctoral trainees in the form of quiz and debate sessions. And this has really been authenticated already by an enchanting experience, an interactive session between Dr. Amit Chakraborty and our own Dr. Vibhash Ranjan Kundu. Dr. Amit Chakraborty is a well-known urologist from Poplar Bluff Urology Center, Missouri, US. He received his medical degree from the MKCG Medical College, Berhampur, and has been specializing in functional urology for the last 20 years. And as we have just witnessed, it was truly a wonderful experience. So without wasting any further time, we will move to our next session, the Symposium 2. The topic is the evolving trend in the treatment approach of metastatic CRPC and the significance of genetic testing. The speaker is Dr. Vivek Agarwal, who is a consultant oncologist, uro-oncologist from the Narayana Multi-Speciality Hospital, and the session will be also moderated by Dr. Sandeep Gupta. So, sir, the dais now belongs to you. Thank you.
Good morning, everyone. Many thanks for inviting me here. Looks like a really busy conference in the going and a lot of academic stuff ahead. So going ahead straight with my talk. So I am talking today on the evolving trends in metastatic castrate-resistant prostate cancer and the significance of genetic testing. So just a word on non-metastatic castrate-resistant prostate cancer. So in the decades earlier, we hardly used to get non-metastatic castrate-resistant prostate cancer. But whenever we used to get, the idea was to only observe these patients because they were just having rising PSA values without any clinical or radiological progression, no metastasis. But now we have three good large studies which are looking at second generation AR blockers, enzalutamide, apalutamide and darolutamide. And all these studies, they had metastasis free survival as a primary endpoint, and the updated results have shown that even the overall survival is improved by a good 10 to 12 months margin in all these studies. Now, even in non-metastatic castrate-resistant prostate cancer, we have evidence to use these molecules and not to observe them, and especially to discuss this if the PSA doubling time is less than 10 months. Going to metastatic prostate cancer, till 2 decades ago, we hardly had any option of any treatment. 2004, TAX 327 data came, and this was for the first time we had docetaxel improving overall survival in metastatic castrate-resistant prostate cancer. What we were able to reach is a survival of around 19 months once CRPC was diagnosed. And then we discussed regarding how to use it better, docetaxel. We found that 2 weekly was a slightly better way of using with almost equal or a better survival with lesser toxicities. How many cycles of docetaxel to be used? And we learned that probably 10 is the number. We should use at least 10, not less than that, but we can use if the patients are tolerating well. And now in 2021, 2 decades later, we have so many treatment options. So currently we have 8 treatment strategies, all with overall survival advantage once CRPC is diagnosed. So all these treatments, they have to be given with androgen deprivation therapy, and all these treatments we will be discussing further in the hormone sensitive setting. Also nowadays only giving androgen deprivation therapy is suboptimal, and we have learned that we have to use some of these either of these three agents that is commonly used in order to improve overall survival. Either you use docetaxel, or you use abiraterone, or you use enzalutamide in addition to ADT. And in CRPC, we already have all these drugs. We have two taxanes, cabazitaxel, docetaxel, we have abiraterone, we have enzalutamide, we have radium, we have lutetium treatment, we have immunotherapy, we have PARP inhibitors, and so on and so forth. So, 2 decades ago, what we are looking at a survival of around 1 to 1.5 years, and now we are looking at a survival of at least around 4 years once CRPC is diagnosed, and this is like a remarkable change in the next, and probably we are going to improve further. Abiraterone, again, we have evidence to use both pre-docetaxel as well as post-docetaxel once CRPC is diagnosed, both with overall survival advantage. One thing we must note that when it was used pre-docetaxel, patients with visceral metastasis was not included in that study. Enzalutamide, again, we have ample evidence in both these studies, AFFIRM and PREVAIL, as to improving overall survival both in pre-docetaxel setting and post-docetaxel setting. Cabazitaxel also came post-docetaxel in the TROPIC, and the Firstana study said that it can be used even in the pre-docetaxel, and 20 milligram per meter square and 25 milligram per meter square both are equally good, and 20 has lesser toxicity. So now the $1 million question actually comes that we have so many treatment strategies, and what is the optimal sequence? And this is not known because hardly we have trials which is actually addressing the sequencing in a prospective fashion. Most of the conclusions are drawn from post hoc analysis of studies, retrospective studies, and large SEER database results. So the idea is to use right drug at the right time for the right patient so as to choose among these 8 treatments. And OS benefit seems to be smaller whenever we are using these drugs in subsequent lines, but when using earlier, then the OS benefit seems to be more. So I will look at some of the pearls in metastatic CRPC treatment without going into the intricate evidence. So what we have seen is that there is poor response to abiraterone post enzalutamide, and there is poor response to enzalutamide post abiraterone. You can't sequence these 2 drugs one after another, and there is a cross resistance between the 2 different types of ART, but if you are sequencing a taxane in between these 2 hormonal agents, then probably the survival is better, the responses are better. Also, there are patients who would be having primary resistance to androgen deprivation treatment or to these AR directed treatments. This is seen when we look at both the abiraterone and the enzalutamide establishment studies. So, one of the potential biomarkers which defines primary resistance is ARV7. This is something that is probably going to come in the clinic. We would be doing these patients to check which patients have ARV7. Again, high Gleason score is also one of the markers where we won't want to use hormonal strategies. In the hormone sensitive setting, still high Gleason score abiraterone data is very good, but in the CRPC setting, high Gleason score is still a relevant biomarker to choose chemotherapy rather than using an AR directed treatment. Also, if you have a short response to prior ADT and your Nadir PSA is less, if the response to PSA is less than 30%, it indicates that probably they are not having that much hormone sensitivity, and probably it is better to switch to chemotherapy earlier rather than to continue with hormone directed treatments. And one thing also is very important is to assess our patients radiologically. Remember, 25% of CRPC patients will not have a PSA progression, but they will still have a radiologic progression. So we must have a strategy of evaluating radiologically our patients at least in 6 months or in a year or so, because if we keep on waiting for clinical progression to happen, then these patients are going to miss out on these 8 important treatment strategies that are there. Survival is going to be maximum if you are able to expose our patients to maximum treatment lines rather than to lesser lines. And therefore, one of the things that I want to convey to our all urology colleagues is that The easiest drug to give is not always the best. We need to select our patients whenever we are prescribing treatment for our patients. And there are patients who are going to benefit from chemotherapy earlier rather than giving them enzalutamide or abiraterone early. Talking about sequence, cabazitaxel is one of the drugs which has been used very less often, and this is one of the keys because you need to expose your patients to this drug, and it remains post ART when there is progression. It is still active when there is ARV7, and studies have shown that it is still active even if you are using it in primary resistance, even if you are using it post docetaxel. HSPC era, we are going to have most of the patients being already exposed to either of docetaxel or abiraterone or enzalutamide when they were hormone sensitive. And when they are castrate resistant, what is the ideal way to go? Re-challenging with docetaxel is not the way. We have already learned from GITOG study that if you are re-challenging with docetaxel, once it has been already used in the hormone sensitive setting, it is not going to give you good results. So do not re-challenge, and post docetaxel, if the ADT has been given for more than 12 months, you can still give some of the hormonal agent, but if it is less than 12 months, cabazitaxel is the drug to go when the patient has CRPC. Again, when you are talking about the sequencing of the two taxanes, most of the registry studies, most of the retrospective data has shown that probably the best sequence is docetaxel followed by cabazitaxel followed by an AR-directed treatment. Now, we also have drugs to prevent skeletal complications, and both these drugs, denosumab as well as zoledronic acid, have shown that they prolong time to skeletal events, and they are important component of treatment so far as CRPC is concerned. In hormone sensitive setting, we may not use them, but in CRPC, we need to use them more often. So when you talk about conclusions regarding sequencing of these drugs, we have to again reiterate that sequencing one ART after another has poor responses, but with a taxane in between, we can have better responses. There are biomarkers of hormonal resistance, and in these settings, taxanes are preferred to using hormonal agents. What are these? ARV7 positivity, high Gleason score, visceral metastasis, lack of an early PSA response or a deeper PSA response to ART, and a short response to prior ADT, that is less than 12 months. Also, we need not to rely only on PSA. Frequent imaging is something that we need to do to intervene early, and we need not to wait for clinical progression. There is cross resistance even between ART and taxanes, and in these patients, cabazitaxel is not cross resistant, it can have better outcomes. And when there is CRPC post early docetaxel in HSPC, then docetaxel re-challenge has poor results. ART can be used if it is more than 12 months, but if it is less than 12 months, we have to go for cabazitaxel. If abiraterone is used in HSPC, then probably the best sequence is docetaxel, cabazitaxel, then enzalutamide. And we need randomized studies in this setting, which probably may or may not come because these are going to take a lot of time. Survival is highest if you are exposing to all the agents, and window of chemotherapy should not be lost. And patient preferences, performance status, affordability, fitness, all these are something that we need to consider. Now, going beyond these four agents, we still have usage of platinums. We have immunotherapy being used, especially if they are PD-L1 positive, MSI is high, or they have a high tumor mutation burden. If there are homologous recombinant repair pathway alterations, then we need to use PARP inhibitors. There is talk of using AKTI inhibitor ipatasertib in combination with taxanes if there is a PTEN loss. Cabozantinib may come up. Then we have two radiopharmaceutical agents, radium-223, which has shown OS benefit as per the L-Simpica study, and as per the Vision study, lutetium treatment has shown also OS benefit in CRPC. Now, talking about genetic testing, the later part of my talk, I'll take just 2 minutes more. So, in metastatic CRPC, we need to understand what are the actionable alterations for our patients. And 70% of these patients, they will have mostly an AR-driven pathway of the disease. But the 40% patients may have PI3K, AKT, mTOR pathway alterations. And DNA repair deficiency is there for almost 25% of the patients. Further 25% patients may have cell cycle regulatory defects. And all these alterations, if detected, are amenable for targeted treatment. In the era of precision medicine for advanced prostate cancer, we need to understand beyond the AR-directed treatment, we have PI3K-AKT inhibitors, we have cell cycle inhibitors with CDK4/6 inhibitors, rampantly now being used in breast cancer, and we have PARP inhibitors and platinum drugs, as well as immune checkpoint inhibitors whenever there is a mismatch repair deficiency or a DNA repair deficiency. If we talk about alterations in DNA repair deficiency, it is detected in almost 23% of the CRPC patients. 8% of the patients, they harbor germline mutations either in the BRCA1, 2 or the other associated genes, and 13% of the patients can have BRCA2 mutation, either somatic or germline. And this was the profound study which looked at 2,800 prostate cancer tumor samples, and 28% of the patients were having HRR mutations. Most of them were BRCA2, 9%, but then there were also BRCA1, ATM, CDK12, CHEK2, RAD1, and so on and so forth. And you look at the profound study where in the cohort A, they included only BRCA1, BRCA2, and ATM deletion patients. We see a significant overall survival benefit while using olaparib as against placebo. And in the cohort B, when they included all the HRR patients, they saw still a small benefit in the selected subgroup of patients of BRCA1, BRCA2, and ATM only. When you include all these major HRR genes, the benefit was not there. Maybe because of a smaller sample size, maybe because of the 2:1 randomization, but still cohort A study were very significant. And if you look at other PARP inhibitors, we have olaparib as per toparb Triton, we have rucaparib, we have talazoparib, we have niraparib, and all these studies, they have shown significant responses. BRCA2 patients are the ones that are responding most, followed by the other ones. And nowadays, in order to identify these mutations, either somatic or germline, we don't need to tissue biopsy also. ctDNA testing right from the blood is good enough to know these mutations. So if you talk about ctDNA analysis from peripheral blood, liquid biopsy, it is a non-invasive, results come in 1 to 2 weeks. There is a good 90% concurrence rate with tissue biopsy also, and the overall test pass rate, feasibility for the patient is much better.
Can
and if
we
we talk about guidelines,
Dr. Vivek, can we?
Yeah, this is the last slide. So if you talk about guidelines, whether you look at NCCN, whether you look at the European guidelines, all these guidelines have shown that genetic testing of tumor is something that need to be considered in all risk stages of prostate cancer, even in the early, very low risk, as well as in the metastatic state. So genetic testing is something that is going to give us more insights in future. So to conclude my today's talk, today in 2022, we have a wide array of treatment agents for metastatic CRPC. We have AR-axis agents, we have chemotherapy, we have bone-targeted agents, and we have radiopharmaceuticals, and we have PARP inhibitors. There are total 8 agents which prolong overall survival, 2 delay skeletal-related events, and the OS has tripled in the next 20 years. Challenges remain in patient selection as well as in selecting correct patient for the correct time, and this is something that we urologists and medical oncologists need to sort out. Probably we need to see it more often together to select our patients for the best treatment, and the best sequence yet remains to be known. With this, I thank you again for patient listening, and if there are any questions, I'll be happy to answer. Thank you.
Thank you, Dr. Vivek. It was a very nice talk. Now the house is open. Any questions from anyone? Yes, sir.
Gene fusion. This is one of the latest thing which diagnoses this metastatic cancer prostate very early. And any view on this?
So, sir, the the TMP ERSS gene fusion is something that is seen in almost 70% of the patients when they have castrate resistance. This is more of theoretical in origin, where they have found out that this is one of the fusions which is responsible for castrate resistance. However, we still do not have a targeted treatment still available for this fusion mutation if it is present.
The advantage is that it is urinary based.
Correct.
So it is.
And the only thing that this fusion says that these patients are probably going to be platinum resistant, and platinum is not going to work when this mutation is present. But therapeutically, what this mutation is can say is one of the reasons why the resistance, the castrate resistance is there. And for therapeutic utilization, we are still on the road for this fusion mutation. But yes, this is one of the mutations that has been seen in the the lab studies which look at what is the somatic reasons for the castrate resistance.
Okay, thank you, Dr. Vivek. Any further questions? Okay, so we close this symposium here.
Thank you.
Thank you, everyone.